Hi everyone and welcome to the ECG case series. This is Hesham Ibrahim. I'm one of the emergency medicine consultants in United Kingdom, and today we are going to discuss case number 19 from our Facebook page. Before we make a start, I'd like to announce here about this course, From Zero to Hero in Acute Coronary Syndrome ECGs. This is a new online course that you can do on your own pace, in your own time. It includes 14 different modules that covers almost all what I know about acute coronary syndrome ECGs. There's about 10 hours of ECG training there, including videos and questions and answers that I hope that you will find useful. So please check it out and send me your feedback. There is currently a 10% discount offer that you can get if you use the promotion code that I will include in the show notes of this video. So check it out and let me know your thoughts. Okay, so without any further delays, let's move on to our case. So the case that we're going to talk about is actually one of the most complex cases that I've ever had in my career. This was a 39-year-old male patient presented to University Hospital of Southampton Emergency Department with a weak history of just feeling generally unwell, seen already by the GP, diagnosed as having some sort of a non-specific viral illness. Then he had some diarrhea and vomiting for a couple of days and then presented to the emergency department. Looking at the previous medical problems, actually normally fit in well, not on any regular medicine for any reason. The patient walked in, seen by the ED receptionist first, who didn't like what he looked like because he looked unwell, lethargic. So she was concerned, so she asked one of the senior nurses to come and review the patient. The senior nurse checked the patient and agreed with the receptionist that something is wrong here. So she took the patient to one of the assessment room to take some observations there. So his observations on arrival were as you see here. So as you can see, we've got here the patient is tachycardic, the patient is tachypneic, and the patient is hypotensive. So that was really concerning. So the nurse immediately moved the patient to the resuscitation room, asked me to come and review the patient. Put the patient on the cardiac monitor, and we found sinus tachycardia with the rate of 135, as you can see here. So immediate actions were needed. So immediately we've managed to insert and get an IV access. We've taken some blood samples, and we have done a venous blood gas in addition to so many other tests that we've sent to the lab. The blood gas showed the following. So here's the blood gas of this patient, and as you can see here, we've got so many concerning things here. To start with, this patient is acidotic or acidemic, to be more accurate. So the pH is 7.16. So there is some sort of an acidemia here. The PCO2 is 7.4, which is that's in kilopascals, which is equivalent to 53 millimeter mercury. This is actually a venous sample, so it is definitely less than this in the arterial side, so we cannot really comment on that. But we can definitely say that there is a metabolic acidosis here, looking at a bicarb of 18.2 and a base deficit of minus 10.3. There is also a really concerning lactate and blood sugar with a BM of 11.7, that is in millimole per liter, so it's equivalent to about 200 of milligram per deciliter, and a lactate of 12, which was the most scary feature here. So when I saw this gas, I was immediately concerned. I asked for some IV fluids to start, and I've asked for blood ketones to be done, because this patient has got a metabolic acidosis plus high blood sugar, not that high, but high enough to be concerned about a possible DKA. So blood ketones were done and they were normal. So this was not a case of DKA at this stage. So the initial impression was that he's probably severely dehydrated because of the diarrhea and vomiting, and probably developed some sort of a pre-renal failure. So as I said, IV fluids were given, IV antibiotics were given as well in case this is a possible sepsis, and I tried to take a detailed history and to do a detailed examination for him. There was nothing found in the past medical history, as I said before. There was no travel history, no other findings on examination, no fever, and he denied any chest pain or shortness of breath or any abdominal pain. So no clues yet regarding what's going on. And actually, when I tried to dig a bit further into the diarrhea and vomiting, I found that he vomited only 2 to 3 times in the last 24 hours, and he opened bowel just 3 times in the last 24 hours. So actually that was a bit odd, because this is not enough for a young fit male to develop that severe dehydration and to develop this blood gas and this high lactate. He also started to complain of a weird lower back pain while he was in ED. I've done a full spine and neuro examination and it was completely normal. No tenderness, no nothing, no focal neurology. So was really weird. But what was really surprising was the fact that the renal functions came back as normal. And when I saw this, I was like me and the nurse, like that. So very surprised. And this is the point when I started feeling that something is not quite right here. I'm missing something here. So my plan was to repeat the blood gas and give after giving the fluids and see where we are. So a repeat venous blood gas was done after 1 liter of IV fluids, and the repeat blood gas showed a lactate that moved from 12.1 to 14. Heart rate increased to 190, and that was really scary. This was the point when I decided that I'm definitely missing something here. This patient is going in the wrong direction and I'm not really sure where to go. So my plan was, I need to do 2 more things before I start calling for help from every single senior clinician in the hospital. My decision was to do a chest x-ray and an ECG. And after this, if I don't get the answer to what's going on, this is the time to call for help from every single person. Because by this point, I have gone through the list of every single cause of a high anion gap metabolic acidosis, and I couldn't get the answer to what's going on. So, chest x-ray followed by an ECG. This was the chest x-ray of this patient, and this x-ray gave me the first clue of what's going on. So as you can see, we've got an increased cardiothoracic ratio here. We've got a cardiomegaly here, and actually this is an AP view. So I was expecting some sort of a cardiomegaly, but to me this looked a little bit worse than what I was expecting. Then the ECG gave me the answer. So I would like you to pause the video now, have a look at this ECG, see what you think, and guess what you think the answer to this case is going to be. I guess the first thing that you would note when you look at this ECG is actually that the ECG is of low voltage. So let's talk about low voltage ECG here.
So what is low voltage ECG? Well, basically low voltage ECG it's got many definitions. Some of them are sensitive and some of them are specific. And in ED, we're always interested in the sensitive stuff because we don't want to miss anything. So the sensitive definition of low voltage ECG is either or. The amplitude of all the complexes and in the limb leads, they're all less than 5 millimeters. So less than 5, 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 less than 5. So if that is the case, then this is by definition low voltage ECG. Or you can change it a bit and say that the sum of the complexes in lead 1 and 2 and 3 are less than, the sum of them is less than 15 millimeters. So less than 5 anywhere in the limb leads, or sum of 1, 2, 3 less than 15. That is the first definition. Or there is a second definition here, which is the amplitude of the complexes in the chest leads are less than 10 millimeters. And if we apply this to our ECG, we will notice that actually, no, this is not the case in here. This is definitely not less than 10 millimeters, not less than 10, not less than 10, and not less than 10. or the sum of V1, V2, V3 is less than 30. And again, this does not apply in here. If you combine this with that, it is definitely more than 30 millimeters. But the definition of a low voltage ECG said either or. So if the limb bleed rules apply, then you do not really need the chest lead rules, and vice versa. So by definition, our ECG is showing a low voltage ECG because the limb bleeds were less than 5 millimeters. So what can cause this? What are the causes of low voltage ECGs? Let's put this in a nice diagram. So let's say that this is our heart, and this is the sternum, and we're looking from a lateral view. Sorry, excuse my drawing. So that is our sternum in here. And the ECG dots are in here, trying to detect the electricity coming from the heart. So your heart will be producing the electricity that will travel all the way to be detected by the electrodes. Options to get low voltage ECG are going to be either the heart is not producing enough electricity to reach. So that is option 1. And this can happen with any kind of infiltration to the heart, like what happened with amyloidosis or sarcoidosis, or with myxedema and hypothyroidism. It can be because of a big loss of the myocardium, like with advanced cardiomyopathy or with a massive MI. So that is the first option. The heart is not really producing enough electricity, or actually the heart is producing enough electricity to reach, but there is a barrier in the middle. And this barrier could be air in COPD, it could be fluids in pericardial effusion and pleural effusion, and it could be fat with obesity and high BMI. So let's summarize that. Causes of low voltage ECGs. It could be either the heart is not producing enough electricity to be detected, or there is a barrier. The barrier could be fat, could be fluids, and it could be air. If the heart is not producing enough electricity, that could be because of an infiltration to the heart, could be because of myxedema and hypothyroidism, and it could be because of loss of variable myocardium, like with advanced cardiomyopathy and with a massive MI. So in this slide, this is the summary of the most of the causes of low voltage ECG.
Okay, let's go back to our case now to keep going and find out what happened. So back to the ECG of this patient. As you can see, so we've agreed that this patient fulfills the criteria of having a low voltage here, but there are two more other abnormalities in this ECG. First one is the heart rate. So this patient is running fast, so there is some sort of a tachycardia here. And if you look deeper, it might be actually an SVT. So that's the second abnormality in addition to the low voltage ECG. The third one is, let's make it bigger to see it better. If you look at the complexes here, there is an interesting thing. So big complex, small complex, big complex, small complex, big complex, small complex, and that keeps happening throughout the whole ECG. So there is an alternate change in the height between every beat. This is something called electrical alternance. So when you have this triad of low voltage ECG plus electrical alternance plus tachycardia, there is only one thing that you should be thinking of: massive pericardial effusion. So let's talk about electrical alternance and check out what it means. So electrical alternance, as we said, it happens when consecutive normally conducted complexes alternate in heights, and this is produced when the heart is swinging backwards and forwards within a big fluid-filled pericardium, and it is seen in about 30% of patients with cardiac tamponade. So let's have a look at what happens. This is an echo for a heart with a massive pericardial effusion. And if you imagine that your electrode is here, the heart is moving towards the electrodes, so you get actually no fluids in between the heart and the electrode. You get a big complex. and then the heart moves away from the electrode, you get fluids in between, you get a small complex, and that keeps happening with every single beat. So this is the explanation of why it happens with big pericardial effusion, why we see electrical alternance this way. So let's go back to our case to find out what happened. At this stage, I've had few questions to think about. First question was, can SVT alone cause electrical alternance, without pericardial effusion? Could this be all related to the SVT? Well, the answer to this is yes, SVT has been reported to cause what's called pseudo-electrical alternance. So there will be an electrical alternance associated with SVT, and once you fix the SVT, the electrical alternance will disappear. Could this be the situation now? Well, the answer is no, because SVT does not cause low voltage ECG and does not cause cardiomegaly on the chest X-ray. So at this point, I've taken the echo probe and assessed the patient, and I've measured probably the biggest effusion I've ever measured myself. I've measured, I think, about 4 centimeters of pericardial fluids at some views. So this was a case of a cardiac tamponade that is causing all of this. Next question was, okay, so this patient now is in a decompensated SVT by definition because he's shocked and he's got an SVT. Shall we electrocardiovert according to the ALS, ACLS guidelines? Well, we've had long discussions about this, me and the cardiology consultant and the ED consultant, and we all decided that actually this is not going to help much here. The main priority now is to immediately prepare for the pericardiocentesis. The likelihood is that when we decardiovert, if we cardiovert this patient, actually that will be time consuming, and there will be a recurrence, if not failure, of the cardioversion. So there is no point. So the third question was, shall we do the pericardiocentesis in the emergency department resus room then, or shall we move the patient to the cath lab? And looking at to how unstable the patient was, but how long he was in the department maintaining a reasonable blood pressure perfusing his brain, we decided that the best option is to immediately run to the cath lab with this patient to get the pericardiocentesis done there. So I took the patient myself to the cath lab with a pericardiocentesis needle in my hand, ready to go if anything happens. And on the way, he actually self-cardioverted his SVT back to sinus tachy, but he was having runs of non-sustained VTs. So it was a scary transfer. Pericardiocentesis was done, and 1 liter of hemorrhagic effusion came immediately out. A drain was inserted, and 3 liters came out in the next 24 hours. And interestingly, the lower back pain improved shortly after draining the liter out. And till today, I'm not 100% sure why he had the lower back pain. Why did it improve after removing the liter out? So this patient has had multiple investigations, as you would imagine, including echo, CTs, MRIs, blood tests, including HIV markers, autoimmune tests, all what you would imagine that could be done for a patient like this. And the final outcome was cardiac sarcoma. He's had a cancer in his myocardium. He was also found to have liver mets, lung mets, and bone mets, which is very unfortunate. This is actually a very rare cardiac tumor with that low prevalence, as you can see here. So this was the final diagnosis of this case. And unfortunately, when it reached that far, the life expectancy is about 6 months. So I found a nice article on Medscape regarding cardiac sarcoma. It was my first time ever to meet a case like this. So I will add this to the show notes so you can do some readings about it. And thinking about this case now, actually this presentation was really confusing and challenging. There was no clues at all in the history that I could find to expect what we ended up doing. I couldn't honestly see this coming. And this case was also very challenging to treat from the ED point of view, because of all the complex arrhythmias that we've been through, all the difficult questions that we had to think about in a very stressful moment, and also because pericardiocentesis is not a procedure that we actually see or do that often in the emergency department. So it was an interesting case to reflect on and to learn from. And this was it about this case. So let's try to come up with some learning points. We've talked about the low voltage ECG and we've discussed the definition of it. So there are many definitions. One of them is that the amplitude of all the complexes in the limb leads are less than 5 millimeters, or all the complexes in the chest leads are less than 10 millimeters. We talked about the causes of low voltage ECG. We know now that the causes are going to be either because the heart is not producing enough electricity to reach your electrode, or actually the heart is producing enough, but there is a barrier in between, which can be fat, fluid, or air. Generally speaking, low voltage ECG plus tachycardia is pericardial effusion until proven otherwise, and low voltage ECG plus bradycardia is hypothyroidism until proven otherwise. And low voltage ECG plus tachycardia plus electrical alternance, this is a massive pericardial effusion until proven otherwise. And lastly, just make sure that you have some sort of a systematic approach when dealing with any complex case in ED, trying to avoid missing any life-threatening conditions. And this is it regarding our case. So thanks a lot for your time, and I will try my best to talk to you again via a new video very soon. Stay safe.